In terms of management, I mean, this is halfway of the talk, so another 20 minutes or so. We have careful monitoring and recording of events by the bedside staff, which is very important. All units have a log of episodes, what you're noting down. The nurses sometimes note down whether they think it's central or obstructive or mixed, but that's not essential. They can put the precipitating factors, what is relieving the apnea, what they did as an intervention, and should assess the possible associated factors, reflux, anemia, electrolyte levels, and of course, initially you would evaluate for the secondary causes as we discussed. So general measures do help. Position of the baby plays a very important role. Avoid neck flexion and head end elevation may be considered because reflex may reduce to some extent. Prone positioning obviously is a very useful tool which most NICUs use. One of the things we should remember is that before the baby goes home, we should start nursing mainly supine because we don't advise them to put prone in their home. And prone position, we have to explain to the parents that the only reason we do it in the NICU is because we are monitoring continuously, so it is safe. So the SIDS message of back to sleep should be reinforced to the parents, and they shouldn't take a wrong message that I saw the baby prone in the NICU, I can keep the baby prone at home as well. It's very important to maintain the thermoneutral environment, and we should minimize nasal irritation and obstruction for obvious reasons. So coming on to the treatment part, majority may not need any intervention if they are bigger babies, you just monitor them. You can have the prone position and head end elevation, tactile stimulation and oxygen might be needed, and obviously methylxanthines are the main part of the remaining talk. We'll discuss that in detail, and then ventilation as needed. So there are three scenarios, and I would like you to think about whether you would use apnea and when you would start, when you would stop in each of these cases. So the first one is a premature baby, 26 weeks gestation, 900 gram birth weight. Baby is ventilated since birth, received surfactant therapy. So when would you start caffeine and when would you stop? The second one is a premature baby, 32 weeks, 1900 gram, respiratory distress at 2 hours and started on nasal CPAP. The baby was continued on CPAP for 3 days and then came off subsequently and was uneventful. There was no clinical apnea. So how would you approach this case? The third one is a premature baby, 35 weeks gestation, 2.3 kilogram. Baby was with the mother in the postnatal ward and there was a sudden color change episode following a feed. Baby was found to be apneic and limp. So after the resuscitation measures, baby was admitted to the NICU. So you can think about how you would react to these situations, and we will discuss the responses at the end of the talk. So methylxanthines, as we discussed in the beginning, are competitive inhibitors of adenosine receptors. And adenosine is an inhibitory neuromodulator of the respiratory drive. Blockage of the adenosine receptors results in increased ventilatory responsiveness to carbon dioxide, reversal of the central hypoxic depression of breathing. So these two important mechanisms in the central reasons for apnea is reduced. Enhanced force of diaphragmatic contraction, it's a peripheral effect, and we also have improved pharyngeal muscle tone. So you have both central and peripheral mechanisms of action. In addition, caffeine is known to have a slight diuretic effect as well, so it is having another additional benefit, and it might have anti-inflammatory effect in the brain, which we will discuss later. So theophylline is rarely used these days as caffeine is more readily available. I would like to know about the availability in India. I didn't check that part. The loading dose is 4.5 to 6 milligram per kilogram, and that's a loading dose, and maintenance of 1 to 1.5 milligram per kilogram 12 hourly. I used to use that when we were in PGI, and after that I've not used it since I moved to UK. I've been using caffeine all through, and it's readily available here. The cost was a factor initially, but now we have cheaper versions coming as well. Theophylline is toxic, so drug level monitoring is required due to the narrow therapeutic range. And as I said, caffeine is preferred because of the longer half-life, higher therapeutic index, and the lack of need for drug level monitoring. So we have less tachycardia and less GI side effects compared to theophylline. The dosage, we can talk in terms of the caffeine citrate or the caffeine base. So the caffeine base is half of the caffeine citrate dose. Your loading dose can be 20 milligram per kilogram of caffeine citrate, and up to double this dose can be used as a loading dose. In a baby who's having multiple apneic episodes of the first loading dose, you can top up with the second loading dose before you go for the maintenance dose 24 hours after the loading dose. So we have 5 milligram per kilogram and up to 10 milligram per kilogram can be used. Some units use 10 milligram per kilogram straight away for the extreme premature babies and then reduce the dose as they grow, or they may not increase it as a baby gains weight for a period of time. So they grow into the 5 milligram per kilogram dose. And the dose can be adjusted weekly to match the weight gain, or you can let them outgrow it if you have started with a higher dose. 44% of those with BPD and 21% of those without BPD are still receiving methylxanthines at 36 weeks due to apneic episodes or because of the continued need for ventilation in those with BPD. So in my experience, most of the babies stop it by 36 to 37 weeks at least. So examples of caffeine containing drinks that we commonly drink. Can you guess how much caffeine is there and how much per kilogram you're having? So coffee, especially the espresso type, has 400 milligram and the normal coffee probably has around 150 milligram. So for a 70 kilogram adult male, you are having 2 to 4 milligram per kilogram if you drink a strong cup of coffee. And tea is a little lighter in the caffeine content, and Pepsi for a can, you're getting less than 1 milligram per kilogram. Red Bull, of course, is quite strong, and many exam-going students used to take that. Of course, it's not recommended to be taken frequently, and that's going to give you around 2 milligram per kilogram. So this is a kind of comparison with the dose that we are giving the babies. The loading dose is 20 milligram per kilogram. So it's suggested that caffeine should be commenced in all infants at less than 30 weeks of gestation. So if they're below 30 weeks, we ideally give caffeine to all of them, especially with the recent results of the CAP study and so on. And we try to start it immediately in babies receiving CPAP from birth. So this is one of the key things to improve the success of CPAP. So delaying caffeine may not be good for them. If you are ventilating and plan to extubate early as well, you try to give it. For the ventilated babies who are less than 30 weeks, many clinicians nowadays start the caffeine the first day, and we will discuss the evidence for this. Peri-extubation 24 hours before the planned extubation or within 6 hours is the alternative option, which is a more traditional way. So it's up to you whether you decide to start at extubation or you start early, but most people start early these days. Whether you give it within the golden hour or within the first day, it shouldn't make a big difference, and it may be more ideal if the baby doesn't need CPAP. You may wait for the 24-hour period before you give it. So consider starting in 30 to 34-week infants for apnea of prematurity. Of course, if they have apnea, either 1 or 2 episodes, you can go for caffeine. And obviously, if their extubation, peri-extubation dose is given, whether you continue the maintenance dose in the more mature babies, it's optional. More than 32 weeks, for example, you give the loading dose, but you don't need to continue the maintenance unless they are apneic further. So the risk of apnea of prematurity is lower, so you can decide to hold back. The evidence for the benefit of caffeine for brain development is more for the extreme premature babies, or less than 1,250 by the CAP study criteria. So to wean off from positive pressure ventilation as well, you may use caffeine because, as I said, it improves the diaphragm contractility, it reduces the hypoxia-related inhibition of breathing and so on. And post-surgical procedures, it may be used as they are at increased risk of apnea. Usually, we can continue caffeine till at least 5 apnea-free days. And we mentioned earlier that in more mature babies over 32 weeks where there is an apneic episode, you may give a loading dose for concerns of apnea, but many times that alone is enough. So you may make an order that I'm giving the loading dose now and we'll give maintenance dose if any further apnea. So that's quite reasonable. If you stop the caffeine for any reason and you're planning to restart, for example, we stop it for feed intolerance in a baby or altered aspirates because caffeine may irritate the stomach as well. You may restart without the loading dose if it's within 4 to 5 days. It's based on the half-life of caffeine. So all of you are familiar now of the caffeine in apnea of prematurity study or the CAP study, Barbara Schmidt et al. And it was a study which was done between 1999 and 2004, and it has been occupying headlines ever since 2008-2009, since it was published. So the study included 2006 infants with birth weights of 500 to 1,250 gram. They were randomized during the first 10 days of life to receive either caffeine or placebo. It was a very brave decision because to use placebo when caffeine was already well established, the Cochrane review even then had shown definite benefit, that they decided to use placebo and they got ethics approval. This was mainly because caffeine was having some suspected side effects on the brain. They wanted to make sure it's safe to use, and that's why they got the ethics approval. Initiation of caffeine was based on the unit practice, so it was similar to what we use at extubation, for example. or if the baby is on non-invasive, you start it early. The caffeine or placebo are continued until the drug therapy is no longer needed. So that's again the standard practice. The first study evaluated short-term outcomes before the first discharge home, and then they had follow-ups, and now we have up to the 11-year follow-up. Caffeine therapy was shown to be associated with the first report of reduced risk of PDA ligation, reduced risk of BPD, and earlier discontinuation of supplemental oxygen, shorter duration of ventilation, almost 1 week in those needing mechanical ventilation, and lower weight gain, but it was not very significant. There was no difference in the rate of death, abnormal brain ultrasound, or NEC between the two groups. So obviously caffeine was helping earlier recovery of these babies, so less complications. The 18 to 21 month follow-up showed a very surprising finding. They were looking to show caffeine as neurotoxic or to make sure it's not neurotoxic, but they found the reverse effect, that it was actually neuroprotective. So the primary outcome of composite of death, cerebral palsy, cognitive delay, deafness, or blindness at corrected age of 18 to 21 months was looked at. They had 377 babies in the caffeine group which died or survived with a developmental disability versus 431 in the control group. So 40% versus 46%, and this was significant. And caffeine reduced the incidence of CP 4.4 versus 7.3%, and cognitive delay 33 to 38%. So this was statistically significant as well. So this made a lot of headlines in those days, and everyone started using caffeine. And they also had a subgroup analysis which showed that early caffeine is better in terms of PDA and BPD outcomes, so less than 3 days versus more than 3 days. So people started using it right from day one, as I mentioned. So there was no significant difference in rate of death, deafness, and blindness, and the mean percentile for height, weight, head circumference was similar. So the initial weight gain reduction did not show any long-term impact. So caffeine for apnea of prematurity improves survival without neurodisability at 18 to 21 months. So this was their conclusion. The 5-year follow-up study had little attrition, so 15% loss was there, 1,640 babies, and the combined outcome of death or survival was compared, and these are the definitions they used. The combined outcome did not show any significant difference at this stage, so it was 21% versus 24%. There was no difference in the individual indices as well. However, they noted in a later ad hoc analysis, they showed improved motor performance in terms of coordination and other aspects in the caffeine group, and the same finding was replicated. So in terms of incidence of cognitive impairment, it was lower at 5 years than at 18 months. That's because we start getting more specific findings as they grow older. And it's similar in the two groups, 4.9% versus 5.1%. So at that stage, it was a little disappointing that the initial neurodevelopmental benefit was no longer seen. And however, the safety was clearly established. So based on this, there is no doubt that caffeine should be used where indicated, so it's definitely safe. Whether you want to start it early because of the effect being beneficial at less than 3 days versus the later onset, that's a possibility. The anti-inflammatory effect, diuretic effect might influence the above, and as caffeine is given peri-extubation in ventilated babies, this might also reflect babies with milder lung disease. So that's a key point when we come to Dr. Lodha's study, Abhay Lodha's study, which led to more people using it on day one or even as a golden hour. So the babies who received caffeine early were the ones who were already in a better condition. So that is something we should keep in mind. The 11-year study had about 24% attrition, so they had a total of 1,200 children of the same CAP study cohort. And the caffeine-treated children had better respiratory function and also reduced risk of motor impairment. So they did not significantly reduce the combined outcome. However, the motor impairment risk was reduced. So we had 19% versus 27%, and it was a significant difference. And 13 premature infants may be needed to be treated with caffeine to prevent 1 case of moderate to severe motor impairment at 11 years of age, which is a fairly good number. It's interesting that only 1/4 of the cases of motor impairment in this study could be attributed to clinical diagnosis of cerebral palsy. So most of the motor movement disorders in the ex-preterm babies are not due to cerebral palsy, it's due to developmental coordination. And this developmental coordination disorder is what is improved with the caffeine therapy. So in terms of how it helps, we have the reduced inflammation on the brain, either due to the direct effect of the adenosine inhibition or because of reduced hypoxic episodes. Ventilation, as we all know, is also a pro-inflammatory factor, so reducing the ventilatory support might reduce inflammation as well. So reduced hypoxic episodes due to the central neural output and have better white matter stability as a result of all these factors. So hypoxia is known to cause white matter instability. Inflammation affects the white matter. So all these lead to better neurorespiratory outcome as a result of caffeine use. So we mentioned this. Caffeine is a non-selective inhibitor of the adenosine A2A and A1 receptors, and there could be an anti-inflammatory effect as well against the periventricular white matter from reducing hypoxia as well as the receptor effect. However, caffeine may not be a benign intervention. There are studies which have actually shown in animals that cerebral and intestinal blood flow velocity is reduced by inhibition of the adenosine receptors. It also reduces short-term weight gain, increases heart rate, jitteriness, irritability, and seizures. Caffeine was reported to have adverse molecular and cellular effects on the developing brain as well. And there are studies which have confirmed that caffeine actually increases the threshold of seizures in the babies related to IVH or other factors in the newborn period. So caffeine can have adverse effects, so we shouldn't assume it is safe, especially in the acute phase. So use it with caution as well. So the European Consensus Guidelines considers all these factors. All of you are familiar with the 2019 update. So caffeine prophylaxis soon after admission has become the standard based on cohort studies. I will discuss Dr. Abelloda's study as well before I finish. A clinical trial of prophylactic caffeine versus placebo was abandoned early. I will mention this study as well by Professor Bankalari's group. Caffeine should be used to facilitate weaning from mechanical ventilation. So this is a grade A1, which is very strongly established. Early caffeine should be considered for babies at high risk of needing mechanical ventilation, such as those using non-invasive respiratory support. So starting early in those needing non-invasive respiratory support, there is no doubt. So even though the evidence is C1, it should be used. But they don't say that we should start in ventilated babies at 0 age, which is the one that we should be careful about when we start. So this study by Dr. Abelloda was published in Pediatrics in 2019, and they had the cohort. It was not a prospective study. It was not a randomized study. They had a cohort which was studied and neonates under 29 weeks were selected. They had two groups. The change of practice was what they used, I think, received within 2 days of birth, and late caffeine where it was received after 2 days of birth. The primary outcome was significant neurodevelopmental impairment as cerebral palsy, BSID score less than 70, hearing aid or cochlear implant or visual impairment at 18 to 24 months corrected age. They had a good number of babies. 1,545 were in the early caffeine group and 563 were in the late caffeine group. So the rates of BPD, PDA, and severe neurologic injury were lower in the early caffeine group, and lower significant neurodevelopmental impairment was shown. The BSID score, cognitive score less than 85, was significantly lower in the early caffeine group as well. So they concluded that early caffeine therapy is associated with better neurodevelopmental outcome in the babies born less than 29 weeks. So this study prompted many people to start using it in the golden hour, and already people were doing it after the ad hoc post hoc analysis in the CAP study as well. However, Professor Bankalari's group started this study, early caffeine and weaning from mechanical ventilation in preterm infants, and this was published in 2018. The study was not published, not completed, because after they recruited around 80 babies, they showed that there was a higher mortality in the one of the groups. So when they unblinded the study, they found that it was in the early caffeine group. So the way I did the study is preterm infants born at 23 to 30 weeks requiring mechanical ventilation in the first 5 days. So they didn't include the ones who are on non-invasive because that group is clear-cut, they need the caffeine. So these babies were randomized to receive a 20 milligram per kg loading dose followed by maintenance right from day 1 or when they were considered ready. The placebo was given, a blinded loading dose of caffeine was given in view of the clear benefit of caffeine at extubation in these babies. They did get a loading dose even if they were in the placebo group, but that was only at extubation. So the age at first successful extubation did not differ between the early caffeine, so it didn't change the course of the lung disease by itself. A non-significant trend towards reduced in the higher mortality in the early caffeine group led to a cautious decision to stop the trial. So this study is warning us that we shouldn't rush to conclusions based on some evidence. Obviously, Dr. Abhay Lodha's study and even the CAP study, the conclusion is not that caffeine is totally neuroprotective. It's just that the babies who received earlier caffeine probably were given caffeine early because of their clinical ability to extubate early. So that is the point we should keep in mind. They were relatively more stable babies, and so they had a better neurodevelopmental outcome when caffeine was given early as well. So caffeine is helpful, but when we give it is still open to debate. In terms of the other modes, we will just run through them because you're all familiar with this. So non-invasive ventilation can be considered even after methylxanthine therapy. The baby has multiple apneic episodes when the infant does not respond to tactile stimulation and when an event requires IPPV to terminate apnea. So this is a slight difference from the point I mentioned earlier that we should be aggressive with starting the treatment. So when the baby is already on ventilation, you don't need to hesitate to increase it to a brief period to re-recruit. And when you have a new episode happening, you need to assess the baby better, and it also involves more expense in terms of the circuit being taken, and also you can wait a little bit to know what's happening, but don't wait too long. Don't delay it, because the more apneic episodes happen, the more the FRC is lost, the more lung re-recruits, and you're going to waste valuable time. So you don't need to strictly follow this. If you're clear that there is no other cause and baby is not responding to methylxanthine therapy, especially in the more small babies, put them back on the high flow or CPAP they were on if you have just taken them off. So be practical in your approach and don't delay re-recruiting the lung in these babies. CPAP is effective mainly for mixed and obstructive apnea. The central component also is affected though when you have more stable chest wall and you don't have the central inhibitory reflex of the distortion of the chest wall. You also have better FRC maintained, so the hypoxia related central drive is affected. So it's not just mixed apnea but also central apnea, but the primary effect is on the mixed and obstructive apnea. And if CPAP is not adequate, NAV can be tried, and NAPPV may be tried if you have the option. High flow may work as well, and it can be used. If persistent episodes, even on CPAP needing IPPV, baby will need mechanical ventilation. So mostly this secondary causes are in the immediate post-extubation period. For example, the baby fails CPAP and presents with apnea. That's because the baby tires out, is de-recruited the lung and is not able to cope. So this is a subgroup of the small babies who are extubated early. You may need to re-ventilate. Usually the ventilator requirements are minimal as the underlying lung condition is good, unless it's a worsening due to pneumonia or other factors. If the hemoglobin is low, as we discussed, you may have a slightly higher threshold, but doesn't mean you transfuse them with the hemoglobin of 12 or 13, for example. If it is 9 or so, you may transfuse them, but not otherwise. Don't have very low thresholds to transfuse, a very high threshold to transfuse, even if there is apnea. So when to discontinue therapy, ventilation and CPAP are weaned as clinically appropriate. And methylxanthine, as we discussed, it's continued till the baby is free of apnea for 5 to 7 days at a gestation between 32 to 34 weeks. It's a longer period if the apnea persists. So the more premature the baby, the longer you are going to continue it. It's preferable for the baby to be off methylxanthine for at least 5 days. Most units continue the methylxanthine if the baby continues to have BPD because of the additional benefits. And if the baby is needing non-invasive ventilation, you keep it on till you're off the non-invasive ventilation first. Home cardiorespiratory monitoring is not routinely offered. In some cases, as we said, you may consider it. So in terms of outcome, obviously anything related to hypoxia may cause neurodevelopmental delay. So repeated apnea could cause neurodevelopmental delay, but in terms of regular apnea of prematurity in otherwise healthy baby, there's no evidence that it causes a neurodevelopmental problem. So it's more related to the extreme prematurity, the other factors related to the brain development that lead to the neurodevelopmental problem, not just the apnea itself. However, recurrent hypoxic episodes are not good for any baby, and you do need to be aggressive with the treatment if they have significant hypoxic episodes. There is no clear evidence, as we said, but you have to monitor them as you would for any premature baby. So coming back to the 3 scenarios, I think you might have already deduced the answers based on what we discussed. So this baby is a preterm 26-weeker, ventilated and given surfactant. So there is no doubt caffeine needs to be given for this baby. So you can either give the caffeine soon after the decision for extubation is made. You can use within the golden hour. I'm not sure, I'm not convinced that it is necessary. You could give it within the first 24 hours for these babies because they are likely to need it, and you could extubate early in most of these situations if the baby is not ready for extubation at 2 hours, as in this case. The maintenance dose of 5 milligram per kilogram is continued usually till 34 weeks or longer if there is BPD, and a higher dose can be considered if there is persistent apnea, the 10 milligram per kilogram dose. The second case was a preterm 31 or 32 weeks with 1,700 gram. The respiratory distress at 2 hours and started on CPAP. So there was no clinical apnea after the CPAP stopped. So in this baby, you could start on caffeine after the loading dose from day 2 to 3, or even early on, and it stopped at 34 weeks if the apnea is free, if the baby is apnea free for 3 to 5 days. You can also start if apneic episodes occur, so you could go either way. And in terms of the 35-weeker, obviously the color change episode is more like an aspiration episode or incoordinate or medication effect or something, or even sepsis. So it's very important to evaluate. It's unlikely to be apnea of prematurity. It's a 35-weeker who suddenly had an apneic episode in the ward with the color change. So other factors have to be evaluated, and you have to be careful about not missing infection. For example, in this baby, you may consider a loading dose of caffeine after the evaluation. And as I said, you may not need to continue the maintenance dose unless there is any further apnea. So to conclude, apnea of prematurity is a very common clinical problem in the premature babies. Methylxanthines are commonly used with CPAP or ventilation as needed. The CAP study results show possible neurodevelopmental outcome benefit of caffeine. However, there is still controversy on when to start caffeine in the extreme low birth weight babies who are not on non-invasive ventilation. That is, in the ventilated babies, whether you want to give it right from day 0 or you wait till 24 hours or even at extubation. So the outcome is good, and apnea usually resolves in almost all babies by 36 to 43 weeks or so. So it was a detailed presentation. I'm sorry about the length of it, and I hope we have some time for questions. Thank you.